Penetrating trauma is an injury caused by a foreign object piercing the skin, resulting in damage to underlying structures and an open wound. The most common types of penetrating injuries are gunshot wounds and stab wounds. Clinical features and diagnostic studies vary based on the type of penetrating trauma and the injured region of the body. The assessment of patients with penetrating trauma follows the systematic evaluation outlined in Advanced Trauma Life Support, ATLS primary survey, transfer to a trauma center, if indicated, secondary survey, and tertiary survey. Management involves treating immediately life-threatening injuries and surgical repair of traumatic injuries. See also management of trauma patients and blunt trauma. OCO. Overview. Management of penetrating trauma is based on the type and location of the injury. Stab wounds, IL-2. Cent epidemiology, 1,500 people die from stab wounds annually in the U.S. 3E mechanism of injury copyright caused by the thrusting action of a pointed object, example knife, broken bottle, copyright the depth of the injury is usually greater than the width. Copyright tissue is lacerated and torn along the path of the object. Copyright only remove impaled foreign bodies, example knives, in settings where definitive hemostatic control is possible, example operating room, as they might be tamponating injured blood vessels. 4. Gunshot wounds, GSWs. IL-2. Cent epidemiology. Copyright mortality rate for gunshot injuries in the U.S. is 10.2 per 100,000 adults. 5. Copyright most deaths are due to firearm-related suicide rather than homicide, 2:1. 6. Mechanism of injury copyright tissue is lacerated and crushed along the path of the bullet. Copyright tissue is displaced forward and radially, resulting in cavitation and pressure injury of nearby structures. Copyright the level of injury is related to the kinetic energy of the bullet. Energy varies based on factors such as bullet weight and velocity. Copyright dense organs, example liver, bone, absorb more kinetic energy than less dense organs, resulting in greater injury. Sites of penetrating trauma. Penetrating trauma by body region. Location injuries management. Head penetrating head injury * C traumatic brain injury management and open head injury. Tracheobronchial injury, esophageal injury, vascular injury, example carotid artery, vertebral artery, jugular vein, * C approach to penetrating neck trauma. Cranial nerve injury, example vagus nerve, recurrent laryngeal nerve, pneumothorax. Neck. Cardiac tamponade hemothorax, pneumothorax, tracheobronchial injury. Chest * C approach to penetrating chest trauma, diaphragmatic injury, spinal cord injury, fractures, example rib fractures, vertebral fractures, vascular injury, example aorta, vena cava. Diaphragmatic injury, hollow viscous perforation (RSR). Abdomen and pelvis, at 7 * C approach to penetrating abdominal trauma. Solid organ injury, example liver, spleen, genitourinary trauma. Neurovascular injury, fracture * C approach to penetrating extremity trauma. Compartment syndrome. Back collapse, find text outline. Extremity. Penetrating chest trauma. Approach to penetrating chest trauma. 1. Ensure the following components are included as part of the standard management of trauma patients using the ATLS algorithm. Primary survey. Identify and treat respiratory failure and shock, tension pneumothorax, open pneumothorax, massive hemothorax, and cardiac tamponade. See treatment for details. Copyright if at a non-trauma center, initiate transfer to trauma center. Penetrating injury to the torso is an indication for trauma team activation. Copyright perform resuscitative thoracotomy if indicated. Copyright see traumatic circulatory arrest for the management of cardiac arrest due to trauma. Sent secondary survey. O. Examine axilla, back, and flank for wounds that could enter the thoracic cavity. O. Evaluate for penetrating thoraco-abdominal and flank injuries. Copyright. Obtain urgent diagnostics for trauma patients, including CT chest, once stable, C. Diagnostics. Copyright. Assess for indications for urgent thoracotomy. Clinical features. Hemorrhagic shock and / or obstructive shock, example hypotension, tachycardia, respiratory distress, example tachypnea, hypoxia, absent or decreased breath sounds. Penetrating chest wound, example sucking chest wound. Impaled foreign body, example knife, Beck triad. 1. Subcutaneous emphysema. Tracheal deviation. Copyright. Consider cardiac injury in patients with stab wounds to the cardiac box, i.e., a surface anatomy square bordered superiorly by the sternal notch, inferiorly by the xiphoid process, and laterally by the nipples. M7. Diagnostics. C. Urgent diagnostics for trauma patients for a comprehensive approach. Plus bedside assessment, CXR, EFAST. Sent CT imaging in trauma. Copyright. CT chest with 4 contrast. Copyright. CTA chest if vascular injury is suspected. Asterisk. Additional testing, bronchoscopy, esophagoscopy, echocardiography. Copyright. Do not delay treatment of clinically diagnosed tension pneumothorax to obtain radiologic confirmation. I. Treatment. Bedside interventions. Perform the following during the primary survey: sent respiratory failure, RSI and mechanical ventilation. Sent tension pneumothorax, perform emergency chest decompression. Sent open pneumothorax, place 3-sided occlusive dressing. Sent traumatic hemothorax, place chest tube. Asterisk. Cardiac tamponade, perform pericardiocentesis followed by pericardial window, or resuscitative thoracotomy. 1. Loss of vital signs due to penetrating chest trauma, perform resuscitative thoracotomy. Urgent thoracotomy. Sent definition, a surgical procedure performed in the operating room to obtain access to the thoracic cavity to treat acute injuries to thoracic organs, example heart, lungs, esophagus. Sent indications. Copyright. Hemorrhagic shock, example hypotension, tachycardia, O. Massive hemothorax, any of the following. Back collapse. Find text outline. Sent indications. Degree. 7 AO. Hemorrhagic shock, example hypotension, tachycardia, massive hemothorax, any of the following, equals hemorrhagic shock, example need for multiple blood transfusions equals chest tube output equals 1500 ml immediately upon placement equals chest tube output equals 200 ml/hour for 2 to 4 hours impaled penetrating object cardiac tamponade open pneumothorax tracheobronchial tree injury, example persistent air leak, esophageal injury. Penetrating abdominal trauma. Approach to penetrating abdominal trauma, *1. Ensure the following components are included as part of the standard management of trauma patients using the ATLS algorithm. Sent primary survey. Degree. Perform fast exam and portable CXR. Treat hemorrhagic shock with emergency transfusion and immediate hemodynamic support. Identify obvious indications for exploratory laparotomy, example hypotension, evisceration, peritoneal signs, subdiaphragmatic air on CXR. Sent secondary survey. Degree. Examine flank, back, and groin for wounds that could end the abdominal cavity. Locally explore wounds for evidence of violation of the abdominal fascia. Evaluate for penetrating thoraco-abdominal and flank injuries. Obtain urgent diagnostics for trauma patients, including contrast CT abdomen and pelvis, once stable, C. Diagnostics. Identify other radiological indications for exploratory laparotomy. Copyright. In persistently unstable patients with indications for exploratory laparotomy during the primary survey, do not delay operative management, example damage control surgery, for CT scanning. 1. Clinical features. Hemorrhagic shock, example hypotension, tachycardia, scent penetrating abdominal wound, scent impaled foreign body, example knife, asterisk signs of peritonitis, scent evisceration, protrusion of intra-abdominal organs through a wound to the outside of the body. Copyright significant intraperitoneal injury occurs in 98% of abdominal gunshot wounds and 30% of abdominal stab wounds. 1. Diagnostics. Scent general imaging in trauma, CXR, pelvic X-ray, scent bedside intra-abdominal hemorrhage assessment, FAST or EFAST, or diagnostic peritoneal lavage, DPL, scent CT imaging in trauma, degree minimum evaluation, CT abdomen and pelvis with 4 contrast. If penetrating thoraco-abdominal injury is suspected, add CT chest and consider double contrast CT or triple contrast CT. Scent minimally invasive surgical at degree local wound exploration. 1. Diagnostic laparoscopy. 5. Copyright retroperitoneal injuries may be missed on DPL and FAST. HL. Copyright if indicated, do not delay exploratory laparotomy to obtain CT scans. 1. Exploratory laparotomy. I. Scent definition, an urgent surgical procedure in which the abdominal cavity is opened via a midline incision and the 4 quadrants are evaluated for pathologies, example bleeding, perforation, scent indications. Back collapse. Find text outline. Scent indications. Copyright clinical equals hypotension equals peritoneal signs, evisceration equals penetrating injury, example GSW, with a trajectory that enters or traverses the peritoneal cavity equals evidence of GI, GU, or rectal bleeding. Copyright diagnostic equals pneumoperitoneum and / or retroperitoneal air equals diaphragmatic rupture equals GL, bladder, renal, or severe solid organ injury on CT positive DPL. Conservative management aid. Consider the following in consultation with the trauma team for select stable patients without indications for exploratory laparotomy, E 24-hour observation, E vital signs monitoring, scent serial abdominal examinations, E repeat imaging if clinical status changes, scent other supportive care for trauma, see secondary survey for details. Penetrating thoraco-abdominal and flank trauma. Anatomic regions. 1. Plus anterior thoraco-abdominal, penetrating wound between the 4 intercostal space, nipple line, and costal margin extending to the anterior axillary line bilaterally, plus posterior thoraco-abdominal, penetrating wound between the 8 intercostal space, costal margin, and posterior axillary lines, E flank, penetrating wound between the anterior and posterior axillary lines, between the 6 intercostal space and iliac crest. Injuries. Scent thoracic injuries, example heart, lung, thoracic aorta. Scent diaphragmatic injuries, abdominal injuries, example liver, spleen, stomach, bowel. Scent retroperitoneal organ injuries, example kidney, abdominal aorta, ascending colon, descending colon. Management. Scent follow the ATLS algorithm and obtain beside diagnostics, example CXR, EFAST. Scent combine the approach to penetrating thoracic trauma and the approach to penetrating abdominal trauma. Scent obtain CT chest, abdomen, and pelvis with 4 contrast in stable patients. Scent evaluate for diaphragmatic injuries and retroperitoneal injuries. Scent urgent thoracotomy and / or exploratory laparotomy may be indicated. Prioritize definitive care in consultation with specialists. Copyright maintain a high index of suspicion for diaphragmatic injury and retroperitoneal injury in patients with stab wounds or GSWs to the thoraco-abdominal and / or flank regions. WA. CE. Lee diaphragmatic injury. Scent definition, an acquired defect, tear, perforation, or rupture, in the diaphragm that can result in an acquired diaphragmatic hernia. Scent etiology, penetrating trauma, 65%, blunt trauma, 35%. 10 cent clinical features copyright often asymptomatic copyright signs of chest and / or abdominal trauma copyright clinical features of acquired diaphragmatic hernia copyright clinical features of bowel obstruction. Cent diagnostics, difficult to identify on imaging if there is no associated diaphragmatic hernia, see also diagnostics of acquired diaphragmatic hernias. 2OCXR, can be used to screen unstable patients, may show thoracic bowel herniation but has poor sensitivity. Copyright CT chest and abdomen, preferred initial modality for stable patients, findings include diaphragmatic discontinuity, diaphragmatic hernia, and hourglass sign. NM copyright diagnostic laparoscopy and / or thoracoscopy, may be required in select patients. A. Cent treatment, reduction of herniated contents with surgical repair. 11 cent complications, diaphragm paralysis, mechanical bowel obstruction, bowel ischemia. Back collapse. Find text outline. Copyright exercise caution when inserting a chest tube in patients with suspected diaphragm injuries to prevent injuring herniated abdominal structures. T. 7. OE. Penetrating neck trauma. Approach to penetrating neck trauma. Ensure the following components are included as part of the standard management of trauma patients using the ATLS algorithm. Cent primary survey. O. Prepare for difficult airway management and secure the airway early. C. Treatment. Copyright consider C-spine immobilization if a C-spine fracture is suspected, example focal neurological deficit, low GCS, or intoxication, GSW. O. Apply direct pressure to active hemorrhage. Dash. Copyright assess for hard signs of penetrating neck injury requiring emergency surgery. Cent secondary survey. O. Examine neck wound without probing for violation of the platysma. 1. Copyright perform neurological examination. Copyright obtain urgent diagnostics for trauma patients, including CTA neck, once stable, C. Diagnostics. Copyright do not probe penetrating neck wounds as this can cause life-threatening bleeding. Clinical features, 131L2. E. Penetrating neck wound. Cent impaled foreign body, example knife. Hard signs of penetrating neck injury. 21. The presence of any of the following increases the likelihood of life-threatening injury requiring surgical intervention, often bypassing CT imaging. Cent airway or esophageal injury. O. Airway compromise. Copyright wound bubbling. O. Extensive subcutaneous emphysema. Copyright hoarseness and / or stridor. Cent vascular injury. Copyright hemorrhagic shock, example hypotension, tachycardia. Copyright pulsatile bleeding. O. Expanding hematoma. Copyright carotid bruit. Copyright unilateral pulse deficit. Copyright signs of stroke. Soft signs of penetrating neck injury. The presence of any of the following increases the likelihood of serious injury and often requires a CTA neck for further evaluation. Airway or esophageal injury. O. Hemoptysis and / or hematmesis. Copyright dysphonia. E. Dysphagia. O. Mild subcutaneous emphysema. Cent vascular injury. Copyright minor bleeding. E. O. Non-expanding hematoma. Copyright proximity wound. 3. Cervical collars can obscure injuries. Remove the cervical collar and maintain manual inline cervical stabilization while examining the patient. Diagnostics. 2. Bedside assessment, CXR, EFAST to rule out pneumothorax or apical lung injury from supraclavicular neck injuries. Cent CT imaging in trauma, CTA neck. Cent additional testing, varies based on the suspected injury. Back collapse. Find text outline. Cent additional testing, varies based on the suspected injury. Copyright vascular injury, duplex ultrasound, angiography. Copyright esophageal injury, esophagoscopy, esophagogram. Copyright laryngeal injury, direct laryngoscopy, flexible nasopharyngoscopy. Treatment, 1411-2. Cent urgent surgical repair is typically indicated for vascular, laryngotracheal, and esophageal injuries. C. Spine fractures can be treated operatively or non-operatively. See vertebral fractures for details. Airway management 12. If there are copyright assess for hard signs of penetrating neck injury requiring emergency surgery. Send secondary survey o examine neck wound without probing for violation of the platysma. 1. Copyright perform neurological examination. Copyright obtain urgent diagnostics for trauma patients, including CTA neck, 1 stable, see diagnostics. Copyright do not probe penetrating neck wounds as this can cause life-threatening bleeding. Clinical features, 131L2. Penetrating neck wound scent impaled foreign body, example knife. Hard signs of penetrating neck injury 21. The presence of any of the following increases the likelihood of life-threatening injury requiring surgical intervention, often bypassing CT imaging. Scent airway or esophageal injury o airway compromise. Copyright wound bubbling o extensive subcutaneous emphysema. Copyright hoarseness and / or stridor. Scent vascular injury. Copyright hemorrhagic shock, example hypotension, tachycardia. Copyright pulsatile bleeding o expanding hematoma. Copyright carotid bruit. Copyright unilateral pulse deficit. Copyright signs of stroke. Soft signs of penetrating neck injury. The presence of any of the following increases the likelihood of serious injury and often requires a CTA neck for further evaluation. Airway or esophageal injury o hemoptysis and / or hematmesis. Copyright dysphonia dysphagia o mild subcutaneous emphysema. Scent vascular injury. Copyright minor bleeding o non-expanding hematoma. Copyright proximity wound. 3. Cervical collars can obscure injuries. Remove the cervical collar and maintain manual inline cervical stabilization while examining the patient. Diagnostics 2. Bedside assessment, CXR, EFAST to rule out pneumothorax or apical lung injury from supraclavicular neck injuries. Sent CT imaging in trauma, CTA neck. Sent additional testing, varies based on the suspected injury. Back collapse. Fine text outline. Sent additional testing, varies based on the suspected injury. Copyright vascular injury, duplex ultrasound, angiography. Copyright esophageal injury, esophagoscopy, esophagogram. Copyright laryngeal injury, direct laryngoscopy, flexible nasopharyngoscopy treatment, 1411-2. Sent urgent surgical repair is typically indicated for vascular, laryngotracheal, and esophageal injuries. See spine fractures can be treated operatively or non-operatively. See vertebral fractures for details. Airway management 12. If there are signs of airway compromise, call for help immediately, example emergent anesthesia or and consult. Plus prepare for difficult airway management by an experienced provider. 1. Cricothyroidotomy may be impossible if anatomic landmarks are invisible or deformed, example due to a laryngeal fracture. Emergency tracheostomy may be required for a failed intubation. 1. And penetrating extremity trauma. Approach to penetrating extremity trauma. Ensure the following components are included as part of the standard management of trauma patients using the ATLS algorithm. Sent primary survey. Copyright apply direct pressure and / or a tourniquet if there is active extremity hemorrhage. Copyright immobilize fractured limbs early. Sent secondary survey o perform detailed neurovascular examination of the affected extremity. Copyright provide supportive care, example analgesia, tetanus prophylaxis. Copyright obtain urgent diagnostics for trauma patients, including X-ray and / or CTA extremity, 1 stable, see diagnostics. Clinical features. Hemorrhagic shock, example hypotension, tachycardia, sent penetrating extremity wound impaled foreign body, example knife, sent neurological deficit, example loss of strength and / or sensation, acute compartment syndrome. Hard signs of extremity vascular injury, 15. Active hemorrhage absent distal pulses. Sent pulsatile hematoma. Sent new brute. Sent distal ischemia. Diagnostics. See Urgent Diagnostics for Trauma Patients for a comprehensive approach. Cent Vascular Injury Copyright Arterial Brachial Index, ABI, Copyright CTA of the injured limb, 6.0 Duplex Ultrasound Cent Bony Injury, X-ray of the injured limb treatment. Cent Vascular Injury Copyright Hemostatic Control Copyright Consult Vascular Surgery for patients with hard signs of extremity vascular injury or abnormal imaging. Cent Fracture Copyright Immobilize with a splint. Copyright Consult orthopedic surgery and provide antibiotic prophylaxis for open fractures. Back collapse. Find text outline.